Investigation and Management of Post-Surgical Site Infection, SSI. Introduction. Surgical site infections, SSIs, occur in the area of surgery within 30 days postoperatively, or up to 1 year for implants. They are classified as superficial incisional, deep incisional, or organ space infections. Proper investigation and management are essential to prevent complications, including sepsis and delayed wound healing. Investigation of SSI. 1. Clinical assessment. Symptoms: localized pain, redness, warmth, and swelling around the incision site. Purulent discharge or drainage. Fever, 38 degrees or chills. Physical examination. Look for erythema, induration, or wound dehiscence. Palpate for fluctuance, indicating abscess formation. 2. Laboratory tests. Complete blood count, CBC. Elevated white blood cell, WBC count, especially neutrophils. C-reactive protein, CRP, or erythrocyte sedimentation rate, ESR. Elevated levels suggest systemic inflammation. Blood cultures, indicated in cases of systemic signs of infection, e.g. fever, hypotension. 3. Microbiological testing. Obtain a swab of purulent discharge or aspirate from the wound. Perform gram staining, culture, and sensitivity testing to identify the causative organism and guide antibiotic therapy. 4. Imaging studies. Ultrasound, useful for detecting abscesses or fluid collections. CT or MRI. Evaluate deep or organ space infections, particularly in complex cases. 5. Histopathology. In cases where malignancy or other underlying conditions are suspected, send tissue samples for histopathological evaluation. Management of SSI. 1. General principles. Initiate management based on the severity and classification of the infection. Remove any potential sources of infection, e.g. necrotic tissue, foreign material. Optimize systemic conditions like diabetes or immunosuppression. 2. Superficial incisional SSI. Wound care. Open the incision if purulent drainage is present. Perform daily wound dressing with sterile saline or appropriate antiseptic solutions. Antibiotics. It's typically not required unless there is significant cellulitis or systemic involvement. Empiric therapy, e.g. cephalexin or clindamycin, may be initiated if indicated and tailored once culture results are available. 3. Deep incisional SSI. Wound care. Debridement to remove necrotic or infected tissue. Negative pressure wound therapy, NPWT, may aid wound healing. Antibiotics. Start broad-spectrum antibiotics, e.g. piperacillin tazobactam or vancomycin, and adjust based on culture results. Surgical intervention. Re-exploration may be necessary for extensive infections. 4. Organ space, drainage, percutaneous or surgical drainage of abscesses or infected collections. Antibiotics. Prolonged antibiotic therapy may be required, guided by culture and sensitivity. Imaging-guided intervention. Use CT or ultrasound for precise drainage procedures. Special considerations. If prosthetic material is involved, removal may be necessary. Prevention of SSI. Preoperative measures. Patient optimization, e.g. glycemic control, smoking cessation. Antiseptic skin preparation, e.g. chlorhexidine. Prophylactic antibiotics 30 to 60 minutes before incision. Intraoperative measures. Aseptic surgical techniques. Minimize surgical time and blood loss. Postoperative measures. Regular wound care and monitoring for signs of infection. Educate patients on wound hygiene and signs of infection. Conclusion. Prompt identification and tailored management of SSIs are critical for minimizing complications and promoting recovery. Multidisciplinary care involving surgeons, infectious disease specialists, and wound care teams ensures optimal outcomes.